Hello and welcome to another ACL Study Day event. I'm very pleased to have you here for this live question and answer session with our quad dysfunction after ACL injury panel. My name is Matt Bobman, and I'm glad that you're all here. It's my pleasure to introduce our panel of experts. I'm going to introduce all of them now. So first up is Dr. Lynn Snyder-Mackler. She is a prolific author of more than 250 research articles, 30 book chapters and monographs, and textbooks on electrotherapy and sports physical therapy. She serves on the editorial boards of multiple publications and has presented internationally in over 40 different countries. She's also the recipient of numerous awards, including the Catherine Worthingham Fellow, the highest honor in the profession. And in 2009, she won the Francis Allison Faculty Award, which is the university's highest faculty honor. Next is Dr. Dustin Grooms. He's a professor in the Division of Physical Therapy at Ohio University. He has clinical experience as an athletic trainer and strength coach and has degrees in athletic training, kinesiology, biomechanics, and neuroscience. Currently, his main research interest is how the brain and movement mechanics change after musculoskeletal injury and therapy. Next is Dr. Lindsey Lepley. She's an assistant professor of athletic training at the University of Michigan School of Kinesiology. Her research program focuses on the identification of neuromuscular mechanisms and rehabilitation strategies to treat dysfunction after injury. Much of her previous and current research has identified adaptations in neuromuscular mechanisms that contribute to injury and disease, with a particular emphasis on ACL rupture. She'll be joining us a little into our session. Next is Dr. Liz Wellsandt. She's an associate professor in the PT program and the director of clinical movement analysis lab at the University of Nebraska Medical Center. Her current research is focused on how physical activity and movement patterns of the knee contribute to early osteoarthritis and other outcomes after ACL injury. Her work has been funded by the NIH Arthritis Foundation, Rheumatology Research Foundation, and the Foundation for PT Research. Dr. Grant Norte is an associate professor in the School of Exercise and Rehab Sciences and the co-director of the Motion Analysis and Integrative Neurophysiology Lab at the University of Toledo. His research agenda is centered around the neuromuscular and biomechanical burden of joint injury, with a specific emphasis on the neurophysiological origins of post-traumatic muscular dysfunction in patients with knee injury to better understand, develop early intervention strategies to promote long-term health and well-being. So that's our expert panel, and I'm also very excited to introduce our moderator for today, and that's Dr. David Sherman. He's a postdoctoral researcher in the Department of Rheumatology at Boston University and Harvard John A. Paulson School of Engineering and Applied Scientists. Dave applies mobile brain imaging and wearable sensor technologies to investigate the root causes of chronic pain and motor impairments in orthopedic populations. His research develops and tests the efficacy of physical therapy treatments and rehab technologies that restore neuromotor control and reduce the burden of disease through neuromodulation. He's also an expert in return to sport assessment and has piloted the application of interpersonal coordination as a marker for athlete readiness. He has national speaking experience on topics of motor control, motor learning, electroencephalography, and neuromodulation. So I'm happy to have you all here. Thanks for joining.
Thanks, Matt. So I thought we would start with an introduction of the topic from my perspective, and then I'll kind of lay out a framework. We do have a ton of questions on Slido already. And I had a few follow-up questions myself from watching the ACL Study Day course. So first and foremost, I view myself as a researcher and a clinician. I consume a lot of information on ACL rehabilitation, and I see firsthand the challenge that our clinicians have in cutting through the noise and drilling down to what's important in the emerging evidence and how it impacts practice. I think a big theme of the collection of talks from this course was that we must do the basics well. And to do that, we need to focus on providing patient-centered care on their rehabilitation goals in the context of the evidence. And we must also bust commonly held myths that get in the way of our using of the best techniques. And further, we must refrain from abandoning tried and true basics in favor of adopting new techniques and technologies that are not appropriately vetted. For example, if you're using blood flow restriction but not doing open kinetic chain exercises, you're probably missing a step. if you're focused on neurocognitive training post-op day 1, but not prioritizing knee extension in the post-operative stages in patient education, that's quite frankly wrong. So I think all of the panelists for their contributions to the course. It was amazing. I love following you all and catching up with your latest research. And I want to thank ACL Study Day for creating this forum for researchers like us to translate our research, but most importantly, for us to continue to learn from the clinicians in the field. So I've reviewed the questions. I'd like to organize the discussion as kind of big picture successes and failures of our therapies, then move into injury mechanisms and prevention, both primary and secondary, then move into assessment and treatment of muscle inhibition in the quads as an impairment, and lastly, the nuances of specific training methods kind of catches the rest. So because we have a giant in the field in our midst, I want to start just by asking Lynn a simple question. What are the biggest changes in sports medicine that you've seen over your career? What's your vision for the future?
Well, sports medicine in general. Well, I mean, I think in terms of what we are doing as physical therapists over my career, we've had just enormous changes in surgery, right? What they did from opening, I mean, meniscus surgery. What drove why I got into research is, you know, my patients would come in, they'd have a functioning quad into the hospital, meanwhile, right? Come in, have an open meniscectomy, and then they couldn't function. Their quad couldn't function. They'd flex their knee instead of trying to extend it. So what's driven my career is that as a clinician, why doesn't the quad work after surgery? And then when it got to more like minimally invasive surgery, these two little holes in the knee to do the meniscus, it didn't really matter, right? So in terms of what's changed the most, it's that. And then there's some bad changes. We have very much lost the ability in many, many clinics to address these basic issues after intra-articular knee injury. So we don't have devices to measure muscle strength. We don't have devices to train muscles. I think, so there's some, the problems are still the same. I think we've lost the ability in some cases to measure and treat. I hate to be boring, but it's like super basic.
No, I think that's great. I used to work with a team of orthopedic surgeons, and they would always say that physical therapy is a critical component of recovery, but it's just one component, and the surgery itself needs to be good and sets a solid foundation for each patient. And I take your point on the environment that our clinicians find themselves working in. The cup weight joke kind of came up in the course. If you just have cup weights in your clinic, then maybe you should find a friend that can treat your patients with ACL injury or your higher functioning athletes. We need to load these people. Is that right?
Yeah, absolutely. It was funny. I ran into a student, a former student, just during a social event during our alumni weekend last week. And he was married to someone who went to a different physical therapy school, who said she just started reading about the fact that you can do open chain exercise. I'm like, okay, your teachers told you shouldn't do that? Let's find your school and help fix that.
Yeah. So the next question, I think is for Liz. So you showed in your talk, I think the data was from Ohio State. I could be wrong. Again, this is big picture success and failures of our therapy. 45% of people actually pass return to sport criteria for quadriceps limb symmetry. We saw similar rates as a clinician at Texas Health Sports Medicine, and both of these institutions are like highly engaged in research and train or advanced practice clinicians through residencies and fellowships. So like, what will it take for us to do better on the whole, both at these institutions and like more broadly?
Yeah, that's a good question. I think to Lynn's point a little bit is that we're just not measuring. We're not measuring serially and repeatedly during rehab. And so at least what we see a lot is people don't know where they stand until maybe a formal return to sport assessment, if that's even done. And we really find that, most patients with ACL injuries are competitive people, right? A lot of them are athletes. People like to know where they stand, and that can be really motivating and driving to them. And so giving them some of that objective information along the way, I think is well taken by most people. But I think that's something that we are not doing well at all, is just knowing and using that information so that we can change the course of what we're doing with them in rehab, right? We can switch things up if something we're doing is not working. But if we don't measure and understand where people are at, it's hard to know when to progress or change or do any of those approaches. So I think if we could do a better job of that, we're going to land in a better place with some of those rates at return to sport.
Yeah, fantastic. And I wondered if any of the other members of the panel, maybe Grant, you had some input.
Yeah, I mean, I think one, if you look at a system like we use, where we have kind of this plethora of, equipment and assessments that we put patients through, that's nice, but that takes quite a bit of infrastructure and time to develop, both in the lab side and, getting clinician buy-in from the community that you work with. So I think it's really going to be important going forward to have clinically accessible means of assessment. And I think that's, really at the crux of the problem, is understanding where patients, the level they're at to really dictate and inform the treatments from there. So I think that's going to be one thing going forward. Another is, I think, I'm reluctant to say education, but I think developing open lines of communication with the physicians and the clinicians that you work with, because I think, like Liz mentioned, so the information is good. People want it, but then it's always like, what do I do with it? How do I use it? Right. And so actually getting to the point of implementation and using that to inform the direction from that point is, I think, crucial and missing oftentimes.
Yeah, and one thing that came up a bit in the course was how we measure the equipment available. I know many people don't have isokinetic dynamometers. Liz, you shared some data about kind of equivalency of some isometric testing to these isokinetics. And I know, Grant, you and I have talked about a lot in your mentorship of me about making sure this is valid and reliable assessment. And a lot of people you see are buying these new Vault products, these handheld dynamometers, tension gauge dynamometers like Tyndek. And I get the sense that maybe something is better than nothing, but we need potentially resources to train our army of physical therapists that we're doing this all the same way and done reliably. So I think that I wanted to highlight that point that came out of the talks.
Can I just jump in here for 1 second?
Yeah, please do. Yeah.
I think what Liz brought up, there's a paper, if everybody wants to look at it, I'm sure Matt has it on the list, by Anthony Senecor in Journal of Orthopedics and Sports Physical Therapy from the University of Pittsburgh, where they used isokinetic dynamometry as the gold standard. Then they looked at leg press, a couple of different ways of using a knee extension machine. What Liz can probably remind me about this.
Handheld at 90.
Handheld dynamometry isometrically at 90, stabilized with a belt, a mobilization belt. And the best closest is just using a knee extension machine. So if you don't have a knee extension machine in your clinic, you shouldn't be treating ACLs anyway. We're back to the bag weight thing all over again. But you can just use that, a 1RM on the knee extension machine, and it's a very good approximation of the strength of your patient.
Oh, so just to clarify, this is a 1RM assessment of knee extension, not a inline tension gauge dynamometer assessment.
No, just using a knee extension machine is the best approximation. You could do
That
it
makes
partially.
sense.
They did it through a partial range of motion, 90 to 45, and they did it through full range of motion. Both were, there were problems with the closed chain, again, because of the ability of people to compensate with other muscles like the glutes and the soleus.
We have some data that we're just finishing looking at, but we did crane scale at 90 degrees, so similar to handheld and 1 rep max. The 1 rep max seems to very closely replicate what you'll get in isokinetic testing. We tested at 60 degrees per second. The isometric at 90 is consistently underestimating what we measure isometrically at 90 on a Biodex. So again, I think some of the take home is you probably need to use a higher, and this is consistent with that paper from Pitt by Cinecor. But that you probably need, if you want to know that they would test at 90% on a Biodex or a HEMAC, but you probably need to use a higher threshold in the clinic, 95%, maybe even 100%, to feel comfortable that they would test at 90 degrees on a isokinetic dynamometer.
Great. Any other thoughts on like things to move the needle in as far as big picture? Things that we should highlight besides the need for equipment and to do the basics well, and the needs to measure along the way. Okay, so I'm going to move into the next kind of bucket that I had, which is injury prevention, injury mechanisms and prevention, both primary and secondary, I think. And I'm going to send it to Dustin for this. In the methods review of the course, Lynn had posed a question to you about adversarial actions of opponents being necessary for non-contact injury. This clearly plays into your sensory motor prediction error hypothesis and might inform end-stage rehabilitation. So I want to give you the opportunity to reiterate your answer. Are non-contact.
Can I just jump in? I didn't say adversarial. Please. I said there has to be an opponent. That person can be very far away, just in your field of vision. It does not have to be in terms of, they don't need to be interacting with you in any
way. Yeah. Noted. Sorry about that. So are non-contact ACL events due to the nervous system? Should our injury prevention programs change to reflect this? That was a question on Slido.
Sure. So for the first part about like an adversary, so if you go in with this hypothesis, which I think if you just look at these injury events, they look like coordination errors. They look like the person believes, their sensory cortex at least believes their knee is in a location that it's not. Because it almost looks like their foot, they think they have a few more milliseconds before that foot hits the ground. So their muscle synergies are just delayed or off. Maybe their foot, they're predicting it to be a few more millimeters more medial and it's too lateral. And so the synergies are once again off. So if you go in with this idea that it's either a failure of sensory predictions about your environment, which is what you're engaged in constantly. I mean, every region of your cortex is engaged in this constant prediction algorithm, what's going to happen next. Otherwise, we really couldn't function. No, our reflexes are too slow. Even for like just getting across the street, you're always engaged in this sort of interaction between prediction and feedback. So it's either prediction failure, prediction of your sensory cortex to predict where you're going to be in space to generate the appropriate muscle synergies at the right time, or it's an error correction failure. So you have a very fast mechanism between your sensory cortex and your cerebellum to correct for subtle errors in your sensory prediction. So this is why if you're walking down the street and you kind of roll your ankle a little, but you say that you don't fall and smash your face, you didn't have to make a cortical response, that'd be too slow. So you're doing it mostly through the cerebellar mediated prediction correction. Because your motor cortex sends the plan of what you're about to do to the cerebellum, so you can do this like really rapid, just in time sort of updates. Now, if you look at, well, what factors in these sensory motor neuroscience labs increase error rate? So most of these are done in reaching studies, very basic studies, because you have to do like 1,000 maneuvers. And the reason they do so many trials is that you can get an idea of how they're updating their predictions over time, because you would vary their feedback through all sorts of these experimental design, different parameters. All right, so if you have this sort of baseline error ability or error correction ability. Well, if you add distractors, that increases error rate. If you add perturbations to attention, that increases error rate. If you just disrupt gaze behavior, like what they're attending to slightly, even if it's not like a cognitive process, but you just disrupt them in some way, like a loud noise or any sort of distraction, air rate goes up. And then as complexity of the motor skill, air rate goes up. And so then you look at these ACL injury events, like Lynn was saying, and Francisco de la Villa at Isokinetic presented some really great data. He's had a new paper in Journal of Athletic Training. Instead of they look at the biomechanics of these injury events, but they also look like what's going on at the time. And like Lynn was saying, there's almost always someone in their gaze or something else they're attending to. And if you watch these videos, I almost can't stand it. On Twitter, like everyone freaks out. They're like, there was this elite handball player, I forget the country, and everyone's like, oh, she's not strong enough, or she doesn't have enough eccentric control. And I'm just like, you really mean to tell me this like elite athlete, they're just too weak? That's the problem. And that's why they get hurt. I get some people for sure, you need a threshold of strength. I'm not going to argue this, but this constant idea, or like even NFL athletes, and you see them make a non-contact injury, the guy could squat, 600 pounds, and you're going to be like, that's a weakness problem. Anyway, and so if you go in with this idea, they look like coordination problems. And what we know about how your brain organizes movement, it'll organize movement relative to the context or the demands around it. So you generate motor memories in the exact same way you generate any other memory. So if you're trying to study for a test, in the room you study. If you have music playing, it'll help you study. If you can play that music and be in that room for the actual test. You encode memories with all of the emotional, environmental, visual, sensory salience of the event. And so if you think about, I'm going to train motor coordination, I should train it under the same conditions it's going to be taxed in sport. So it's really just like the SAID principle, just applied to the nervous system. It's really not that complicated. If I want to have really good knee mechanics and I want to land really well, then I need to be able to do it moving as fast as I possibly can with defenders coming at me with high stress situation, because you're going to have a slightly different neural activation pattern of resources available to you in that scenario. So a lot of our injury prevention stuff is most of my stuff is all augmented. So if you don't do the basics, like Lynn says, you're screwed from the beginning. So everything I'm tell you, don't even listen to me if you're not even doing that. But this is all we call like an augmented approach. So do your FIFA 11 or your PEP or whatever injury prevention program you want to do. And then we usually just add on this called like a neurocognitive layer to try to, even if you're not going to simulate the defender and all these demands, then you're at least going to have like the online gaze behavior and working memory demands be similar. And so it's really, we do a lot of very simple things where we try to train response inhibition, like do a squat on an even number, do a lunge on an odd number, or whatever, any flash hand signals, stuff you can do in the clinic, in the field with group settings very easily. Joanne Walker and Caroline, two physical therapists that were tasked to provide injury prevention to all these high schools, actually helped them. They implemented a lot of this and published a paper in Journal of Sports Physical Therapy and Sport, where they were like, this is what we learned from the field. This is what you can do. This is what you can't do with a bunch of 14-year-old crazy people, right? And they came up with a lot of really, really great ideas and progressed the cognitive load. So that would be my recommendation, is try to think about the principles that they're going to have to interact with, and then try your best to simulate them. It doesn't have to be sport specific, but just have the same gaze and cognitive challenge at the very least, to simulate the neural demand that they're going to have to deal with.
Yeah, great. I have a follow-up question, came through direct message. So when you're training this, we know that we train muscles and they hypertrophy and they get stronger. How do you become more neurally efficient? You have theoretically a ceiling of neural capacity. So what does this look like under the hood? Do we have, can we pay better attention? Do we use less neural resources to do more work? What does that look like?
Probably your best data for like the neural efficiency hypothesis, mostly in the motor cortex. So it tends to scale pretty well with relative complexity. So what I mean by neural efficiency is the amount of neural activity requires to engage in the same performance. So if I'm an expert pianist, to do simple key presses will require very little motor cortex activity from me, mostly because I'm able to regulate it. It's mostly subcortical structures. And it also doesn't like chunk up your cortical columns like a novel stimulus would. And so if you think about this relative complexity idea, in order to have neural efficiency, your goal would be to have as much exposure as you can. So you need a lot of practice, but you also need practice under those same conditions. And so one thing we try to look for, that we see in our ACL patients, is that the neural efficiency is essentially lost, where they require a lot more neural activity to do the same basic motor task. And then what was the second part of your question? I'm sorry.
I think you've addressed it. Yeah, just like we have theoretically a ceiling of neural capacity, and how do we get better at this? Like,
and so, because when you hit that ceiling, especially then when we see the error rate starts to go up for almost any task we care about. So you essentially have to bring that down. And a lot of the ways we maybe prescribe therapy may encourage it. So you can like get immediate performance boost in the short term. If you like just stare at your muscle, make it as strong as you possibly can, you'll do better now in the moment. Sometimes you have to do that. But eventually your patient has to engage in a very complex coordinated action and have really good quad activation without thinking about it. And so it's like that sort of jump to make.
Great, thank you. So along the injury mechanisms and primary and secondary prevention, I thought I would bring up something that wasn't discussed in the course. And especially this goes to you, Lynn, because you're an author on a response to this paper. But given the challenge that our patients face in achieving return to sport criteria for reducing secondary injury risk, a systematic review by Tim Hewitt and Kate Webster found that there's kind of like maybe an adverse effect where we might have higher contralateral injury by as much as 200%. Now, Jacob Kaplan and you, I think, Lynn, were on the paper, wrote a response to this that challenged this result. So maybe you can talk a little bit about this.
Yeah, it's that part about the contralateral is just a small n phenomenon, right? In that we actually just reanalyzed the exact same data that they did. The big problem with the secondary prevention literature is exposure. And I think we brought that out in that paper, right? Most of the papers looking at population, right, a population group, will put the numerator of injuries over the denominator being the entire population, even though maybe only 50% of them return to sport. So we all know that their chances of being injured are pretty much zero, re-injured, if they don't return to level 1 or maybe level 2 sport. So what we need is to have that exposure part elucidated. And I think we took care of that was part of the issue in the differences. But I think it's very clear that if people meet basic criteria for a return to sport, you can do more. I think what Dustin was talking about, I think that with our ACL sports trial, which Liz knows a lot about, we ended up with 100% of our patients going back to sport within 2 years, right? Almost all of them were level 1. We only had 1 injury in the men, and we had more in the women, but still, if you look at the fact that our denominator was everybody, realistically, the numbers were small. So just adding a secondary prevention program or an on-field rehabilitation program, something that addresses these issues to that tail end of your rehab, most of which can be done in group format, is a huge win. So I hope I answered your question, Dave.
Yeah, absolutely. That's phenomenal. So as the title of your response goes, we'll keep calm and carry on testing and making informed decisions when returning our athletes to sport, passing kind of multifactorial protocols, and then transitioning back into play remains the gold standard for secondary prevention.
So can I just jump in let me just ask one other question. Can I ask Dustin a question that has to do with this kind of? Dustin, you have that article
of course.
most recently come out that sort of addresses some of the Slido comments and questions that are on here. You actually showed that patients who recover quad LSI early don't have these neurocognitive problems. Is that correct? Or am I misstating?
To a lesser extent. So they have a little bit different neural changes. So what referencing, we just did this paper where those who don't recover quadriceps strength, they really have a lot of this lingual gyrus and this lateral premotor area, the premotor cortex, that helps you program movement relative to visual stimuli. So it seems like those that do not recover quad symmetry, when they go back to sport, they have this big shift towards visual motor control. Those that recover earlier and sooner, they don't have as aggressive a shift. Now, what's weird, the controls won't activate like lingual gyrus at all to do the task. And so what we see is controls are like 0. Our ACLs that recover, it's just like a little, it's not significant, but if you graph it, it looks a little bit, but it's the ACLs that are weak, they seem to drive that effect, if that's what you're getting at, Lynn. The ACLs that are strong are still a little different, but it's those weak ones that really seem to rely on this visual strategy later on neurologically, which sort of makes sense. If you're really weak, you're going to have a timid quad, you're not going to move as well, maybe if other stuff going on. It seems like quad weakness is correlated with almost everything else we care about. So that's probably no surprise.
Okay. I have a kind of a follow-up question to that, Dustin, but I feel like it might be a bit in the weeds, which is maybe a good question for Lindsey as well. But I'm going to say it anyway, and we maybe can revisit it offline. How much does muscle reafference play a role where you have weak quads for longer, you get less sensory input from the electrical contraction of those muscles? Muscle contraction as a sensory input shows up in Lindsey's model for AMI, and maybe kind of contributes to this neuroplasticity in the long term that you're recording, right?
It's a good question. So the muscle is more of a sensory organ than the ligament. Like your GTO spindles is astronomically more innervative, right? So it's not even close. And what's sort of weird related to this question, we're finishing this longitudinal study where we get them early, like within a few weeks of reconstruction, and then around the time they go back to running, and then return to sport. And when I started all this, I kind of thought the ligament and the deafferentation effects, like all those old studies, that would drive all of this. And that was the initial insult. And it looks like it's our therapy that's doing it. So most of my therapy is just from the records of the PTs, and some of my data is better than others, but the ones that get more therapy tend to be doing better because we have quad strength and some other measures along the way. And so it seems like it is, I don't want to go as far as to say like the lack of dosage, but it's definitely something in their behavior or in the rehabilitation that is inducing more of this neuroplasticity than I originally thought. So I would say maybe the muscle part, like if you do a lot of high dosage of physical therapy and you get a lot of muscle contraction, so you're going to have a lot more afferent traffic to the system. I think your intuition is at least partially correct.
All right, and it looks like Lindsey is here. So, hey, congratulations, first of all, and thanks for joining us. I had just asked a question that was about muscle reafference and how that plays a role in kind of neuroplasticity. I think Dusty covered it, but just to know, I credited your AMI model for bringing that up, and it may come up again later. So I'll give you some time to ease into the discussion.
Okay, noted.
So we're going to move into assessment now. We've covered the big picture and then secondary prevention. Secondary prevention. When it comes to assessment, I just want to set the groundwork here. We're talking both about acute postoperative assessment and the priorities of our patients, which would be swelling reduction, range of motion recovery, primarily knee extension, range of motion recovery, and then assessing what influences quadriceps strength in those early stages would be arthrogenic muscle inhibition. And then later down the line, or maybe as soon as just a few weeks, assessment of quadriceps strength or force output itself. And so in the course, it came up that maybe what we should do as clinicians, since it's difficult to assess arthrogenic muscle inhibition with actual neurophysiology laboratory techniques, maybe we should assume that the inhibition is there, at least in the early stages. And I had a question just for the group. Anyone can jump in and answer. But as a physical therapist clinician, my gut response is that really appropriate? As medical providers, we cannot treat what we can't measure. Usually we're having to justify our treatments to insurance reimbursement. And I understand that that many of these patients will have this impairment, but isn't it more nuanced than just it's there or it's not. For example, it's probably more of a gradient where there's more inhibition or less inhibition in any given individual. And so that in the context of a double-edged sword, which is, do we measuring it, does it overcomplicate our decision-making? So I just wanted to get your thoughts, and maybe if nobody's going to jump in, maybe Grant could start.
What was the question?
The question was, is assume inhibition is there really appropriate in post-op ACLR care?
I'm
Yeah,
going to
so-
jump in real quick and say some of the contributors that we know to arthrogenic muscle inhibition are the early impairments, which you're going to do anyway. I mean, you're not saying, yes, we're going to treat swelling. Yes, we're going to treat the post-operative pain, which is obviously transient. We're going to make knees move, which is yet another actively, which is another player in this. And I hope, I don't know, we could talk about this. I hope people are going to use electrical stimulation with a sufficient dose. And that has other good evidence for what else it does besides the inhibition side. So I don't think there's much that we would do differently, just if we measured it. That in our clinic, we do measure that as we do measure using a burst superimposition technique. But it's part of our normal practice anyway.
What's the post-operative time frame that you're testing? Is it 4 weeks?
No, we test them right away. Sorry.
Oh, right away. Wow.
Yeah, I was just to add maybe, I think one of the deterrents to treating something like arthrogenic muscle inhibition that sounds big and scary and complex is just having an adequate understanding of what it is and what it isn't. So Justin Rush, one of my students, put out a survey a few years ago, just looking at knowledge and beliefs related to AMI among athletic trainers. And many of them, even though, a good portion of them knew what it was, less than half were actually treating it. And one of the common reasons that they cited for not treating it was they didn't think they had access to the things they needed to treat it in the clinic. It was difficult to assess, as we're talking about now, or they just didn't know enough about it. And so I think there's definitely, as we talked about before, kind of a keep it simple principle and stick to, the core elements of the problem as Lynn just mentioned. As far as, deciding on a surrogate or surrogates of inhibition, that's probably a little bit of a moving target depending on the nature of the injury, the time of the injury. The neural origins can vary greatly based on those factors. And so I think, obviously strength is probably going to be our top surrogate of the inhibition. It could also, a quality assessment of coordination, the integrity of the muscle contraction, I think can also play a role in that. But obviously a little bit more difficult to objectively quantify.
Great, thanks. So we did have a question on Slido about why do some people get terrible AMI or seem to get terrible AMI and others hardly at all? Why the variability across patients? And I presume this would be in the early post-operative stages where some patients really struggle seemingly for months to solidify a quadriceps contraction.
That's a very good question.
Do we even know why some people get a lot of effusion and swelling and some don't, even if the same, sometimes it's surgeon differences, but sometimes not. Do we even know what the source of that is?
This
You know,
also plays into a question I think that's on there, Dave, about from earlier this week about when some surgeons want PT to start on day 1, some on day 3, some on, the ones who say 10 days or further, I don't know what, do something to say, these are your patients who are going to show up in here and they can't move it's, so I think part of it is time. The earlier you get them, the better. If you get them pre-op and you get them through some of this stuff, that's also, especially active motion, teaching them about what a normal quad, even just does the patella move superiorly, right? Get them to feel it on one side, get them to feel it on the other. That's, I guess, a quality of contraction, but I mean, it's measurable. They're doing it or they're not. Yeah, I mean, I think a lot of this is when you see the patients, and if you see them before surgery, you can take care of a lot of this. It's pretty big because then the therapy is pretty basic. They're all the rehab professionals, and I think our colleagues in athletic training are seeing these patients before they go to surgery. You know, in the training rooms. So a lot of this stuff I think can be handled ahead of time with super basic stuff.
Great.
On the variability thing, that question made me think. There's these 2 older papers by Carol Courtney. She's at Northwestern now, and I always, man, they were really interesting. Small sample sizes, but they're an ACL deficient, right? And she looked at copers versus non-copers, and she had EEG measures, and she found that the non-copers brain looked more like healthy brain. Now they're limited. It's not like the measures I would do. It's a little different kind of measure, but the sensory evoked potential from the knee. So basically you would stimulate distal to the knee, record from sensory cortex, see what makes it up there, right? And so if you blew out your leg and you were a non-coper, it would look more like the control people. It was a little disruptive, but not that bad. And in the copers though, their knee potential was gone. It was very different. And then that was highly correlated to if they would activate their hamstrings early during walking, if they would activate their hamstrings during gait. So it's almost like the brain knows the ACL is gone and develops a compensation strategy with the muscle synergies to account for it. But in the non-copers, the brain, like there's maybe enough of an ACL there, a remnant, or the joint capsule's taken up the afferents, or maybe the PCL, like maybe it adhered to the PCL and there's some afferents left. So the brain doesn't quite know their knee's unstable in that direction. And then they struggle to develop like the active muscle activation pattern to support them. So I just wonder with the AMI idea, are there some people that don't compensate? Because if you didn't have orthopedic surgery, you would probably want your quad to shut down a little, because we see in the fusion models, your soleus and your glute will like come up and your quad will go down to allow you to have some functionality, like to survive and not maybe destroy your knee as fast. But in modern day orthopedic surgery, your brain doesn't know it's reconstructed, so we want the quad to come back, right? I don't know, it's just an interesting idea that there is some variability in these responses. That's the only thing I could think of that's related to this. That's a really good question about, I mean, Grant, you were talking about this in your own study, like finding people with inhibition versus not. If you're interested what you think or what the whole panel thinks, or even in the audience, if anyone has an idea, that's a really interesting one.
Dustin, you brought up something that we studied a long time ago. We had people who were in an MRI, so we were looking at all kinds of things, including volume of the muscle. But we also then built this mock MRI unit and had them do the same kind of thing, right? Where they were doing basically a short arc quad in the MRI, in this mock MRI, and then doing EMG at the same time to sort of see what are we seeing in the magnet and then what are they doing. And the people who were non-copers, we did copers and non-copers, so they actually never shut off their quads when they were doing the shorter quad.
Like it always had like, this low level activity.
Right. And so the other folks, you know, the copers and the healthy subjects, the non-injured subjects, would do a normal, what we would all think about, right? An extension, flexion, and stop, right? Or eccentric back and stop, like on, off, on, off. And for the non-copers, it was on, honor, right? On, honor. It never went off. So they had this sort of, I think we called it a dyskinesia, which is sort of a garbage term, I think, but it was the best we could come up with at the time. And this was probably 20 years ago, right? Glenn Williams, Liz, he was what, how many years before you? Probably 10 in the lab. So it's really interesting, but it was like they cannot coordinate. They know what to do and they're doing it and accomplishing it, but it is not the same way the copers and the healthy subjects are doing it.
Okay, I want to direct this question to Lindsey now. In the context of that, you can't shut the muscle off. Muscle's always a little active. There are differences in how people respond. Your talk for the ACL Study Day course explained the timeline of muscle changes given an ACL injury. And then, that reflected in Dustin's talk about brain changes occurring maybe even before injury, and then there's its own timeline. So how do these all interact, and what is the catalyst, do you think, for the muscle changes that you're seeing in your rats? Is it deafferentation? Is it swelling? Is it pain? Just go ahead and talk through that.
Sounds good. So we have a preclinical model of ACL injury where we give rats non-invasive ACL injury. So we just basically overload the joint until the ACL ruptures. And the idea is that this translates better to the clinic than somebody chasing them around with a scalpel, opening up the joint, and then everything's sort of confounded. In those preclinical models, what we've observed is similar to the clinic is that there's sort of this neural muscular distress at the muscle level, and that comes on first, and it comes on before any marker of muscle breakdown sort of peaks. We've also explored other, sort of stress that the neural environment isn't communicating well with the muscle fibers anymore. But we have also probed it to see is the neural muscular junction in some way deafferentated? And so far our evidence says, the NMJ, there isn't overt marking of this structure sort of being destroyed. It just seems you're sort of turning, the lights are sort of on a dimmer or they're turning off, but the structure of it is maintained. Still, that's at least the best evidence that we have at this point in time. And then it sort of just seems to be kind of a cascade where you aren't getting those action potentials anymore, and other components of the muscles that rely on action potential propagation sort of go haywire. And then it's sort of the cyclical event, which manifests in the sort of the clinical weakness and things like that you see. So from our perspective, it seems that muscles get sick because there's a lack of neural input. And if you are in some way able to give the receiver, the muscle, neural input back, it might be helpful to sort of rescuing the system. So as early as you can, sort of blunting sort of that shut off.
Okay, and that would be done through NMES, presumably, right?
Yeah,
artificial muscle contraction and.
Yeah, so we think that NMES holds a lot of promise if delivered at a sufficient intensity, because that's precisely what it should be doing, right? Is giving action potentials back. But there is, maybe not everybody can tolerate that intensity, right? So we also need to think about I guess offshoots for folks that maybe can't get the NMES at the intensity that they would need. Is there something maybe more downstream that we could give them in conjunction with NMES? And so one of the things that we're sort of exploring at more the basic level is what if we just treat the mitochondria that seem to get sort of muscle mitochondria that seem to get sort of dysfunctional? Can we give them an reagent and sort of rescue the muscle in that way? Other things that we've thought about is, muscle can be neurologically stimulated, not just because there's action potentials coming down, but you can put tension and other things on the muscle, right? So we've looked at the power of using lengthening exercises to sort of wake the muscle up in a pathway that seems to be a bit more preserved. So I think there's a number of sort of different routes, and we're sort of thinking about it at the postsynaptic level to kind of provide more information to clinicians to give them a better roadmap.
Great. Okay, and as we move away from kind of a acute assessment and what's actually going on under the hood, one of the topics that came up a lot in the assessment realm in the ACL study day course was assessing quadriceps strength. And we talked a little bit at the start of this call of how to do it, what this kind of surrogates for isokinetic testing might be, claiming 1 RM max testing for knee extension was a suitable surrogate, and then if possible, an isometric test as well. One of the other things that came up was a velocity-based assessment, and that kind of interacted with your discussion, Lindsey, and Liz. I think you're involved in this conversation, so maybe you can talk about velocity-based training or velocity-based assessment in kind of unmasking some hidden impairments in our patients with ACL injury. Is it just quad strength, or does it matter how they're able to use it?
Liz, do you want to take the first swing at that, or do
Yeah,
you want me to?
I can go first. I'll give it a stab. Well, I think having foundational strength is critical first. I mean, we were talking about early. So you can't think about how powerful or how fast you're turning. You have to have a base strength first. And from an assessment standpoint, I think that's really important then to make, if you are testing isokinetically or even with 1 rep max, like not trying to go as fast as you can, because you're probably going to get fooled with what their underlying baseline strength is. But yeah, I mean, I think during the sessions, we talked a little bit about rate of torque development and whether that might, how fast can you turn the muscle on at a high level, and does that play into kind of our assessment in later stages and thinking about training towards that, and really understanding what we're getting at with that, right? There's a line of thinking that early time point is really the neural input. When we think about rate of torque development, first 100 milliseconds, and then later on, we might be getting a better representation of components at the muscular level, right? And how that's responding and producing force and torque quickly. So yeah, I think that's a area we still have a lot to learn, but certainly something that might help us better understand. Again, when we're thinking about getting beyond the basics first is just making sure you have foundational strength, but what can we look at after that?
Yeah, for sure. And then Lindsey, I wanted to jump in just to give you a bit more to talk on. Motor unit conduction velocity is highly dependent of the size of the motor units that you're ultimately going to recruit. So kind of the intensity of the signal and the speed at which that signal is propagated down the axon will dictate the muscle contraction. So how does that interact with what you study in the muscle being the end effector in the quality of the tissue? Muscle fiber types, things like that.
Yeah, so great question. I'm just gonna touch on like the isometric isokinetic thing really quick, and then I'll sort of pivot. I think the really cool thing about muscle is like it's super predictable and super translational across species. And I think we can take a page from like classic muscle mechanic literature to like teach us about like the power of like measuring force length and force velocity relationships. So looking at the ability, if you have the ability to do any isometric contractions, looking at it over like at 20 degrees, 40 degrees, 60 degrees, right? For a force length relationship. And then for a force velocity relationship, looking at slow speeds and super fast speeds. And the reason for that is these relationships, force length and force velocity, can tell you a lot about like how a muscle is built. And that should tell you somewhat about like what your person is sort of dealing with. So if your person has like deficiencies in the force length relationship, which would be your isometric data, that would suggest to you that they have a loss of muscle volume because they don't have a lot of sarcomeres stacked on top of each other, which is like sort of the Legos of muscle. And there's a lot of data behind that to show that like that's kind of like a really good pseudo measure for like maybe MRI and then a cheap clinical way to do it. So if they have deficits in the isometric relationship over sort of like a number of degrees, that's kind of a volume representer. If they have deficits in the force velocity relationship, particularly on the concentric side of that curve, it's really a pretty good indicator of muscle phenotyping. So are you switching to being really fast twitch? Are you switching to being really slow twitch? And there's some really nice studies that back up these relationships with like pulling muscle biopsies and it being really well related. So I like the idea of incorporating these isometric and isokinetic testing at various angles and various speeds, because it kind of gives you a non-invasive metric of like, am I dealing with a loss of muscle volume in this person? Is it a switch in the phenotyping? Is it a mix of both? So it's kind of really, it's like a patient-friendly way, low-cost way to sort of like get at that metric, and you can also serially measure it over time, right? The other really nice thing about muscle is it adapts to demands. So if you know that your patient is like really like at short lengths, they lack a lot of strength, right? Just train them there, and their muscle will adapt and build more muscle at that sort of like particular component, right? If they're really bad at fast twitch, like super fast speeds, train them at fast speeds and the muscle will adapt. Like muscle's very plastic, it will adapt. It just needs to be challenged in a way where it's sort of like at its weak spot. So not only can you use these relationships to kind of tell you about like how your muscle is, where your muscle is at, you can also train your people at those weakest spots to kind of like improve those barriers. Does that make sense?
Yeah, fantastic.
Okay, you asked another question and I don't remember it at this point in
No,
time.
I think you get at it through the
All right, great.
querying isokinetics at different speeds. You know, it's just the intensity or the cue that we give to our patients on how fast we want them to contract will influence the amount of torque they're able to develop, or what, you know, how many muscle fibers are ultimately recruited to some degree. So I just wanted to do a quick time check. We're at 1 hour. Matt said I have an hour and a half. That's just as a warning. We're moving into treatments. Maybe another 20 minutes or so is what I'm projecting. And when it comes to treatment and what Lindsey had just mentioned, being training a muscle where you see the deficits, whether it's a specific range of motion or muscle length. A topic that came up was this idea of the rectus being different than the rest of the quadriceps and needing to train the quadriceps at different, in different positions of our patients, not just in a long sitting position post-operatively, but in long arc quads and short arc quads and straight leg raises, and with the hip extended and with the hip flexed. I just wanted to highlight that note as we move into treatment. Lynn, you raised your hand.
Can I just jump in? I think that came in specifically about quad tendon graft.
Yeah.
Because the quad tendon graft comes out of the rectus. We're not saying that everybody should be doing quad training with the hip extended, but clear if you have a patient with a quad tendon graft, 100%. That's why they're not getting things back.
Okay, and so you doing your kind of isometrics or tendon health exercises in that hip extended position would be your recommendation.
Yeah, what people complain about with what rehab professionals complain about with the quad tendon graft is the patients are strong when they measure them isometrically at like a biomechanically advantageous position like 60 degrees of knee flexion, but they have a quad lag based like what we would normally think of as a strength issue. Probably not. It's not tendon pull through because of the way that you're training them. So there are a couple of papers out there on this. Quad tendon graft is a different animal. So you just got to make sure. Like we don't really think about training the rectus. It doesn't seem to be. I don't know, Lindsey. Would you know? I don't know, but it just doesn't seem to have the problems. And in all of our volumetric kinds of studies that we've done, the rectus hasn't been the thing that atrophies. So I think this is more mechanical, more like treating a tendinosis because of how the graft is taken. But otherwise, I mean, I never train my patients in hip extension unless laying down for stretching over two joints. unless they have a quad tendon graft.
Okay, thanks for clarifying. Okay, so I'd like to move into the treatment section of this, and Grant had given a great review of disinhibitory modalities and adjuncts to our strength training. I'm definitely, as a clinician, sold on the use of strong NMES to generate as strong of a muscle contraction as tolerable, and the use of focal joint cooling before exercise. I believe crossed eccentrics and crossed exercise are just sound strength and conditioning programming that we should be getting our patients as active as possible in the context of their impairments. But I'm curious, Grant, to get your thoughts on two things. Are there combined effects or interactions if we apply more than one intervention at once, say focal joint cooling and NMES? Are the mechanisms of these complementary in any way? And then I can wait on the second question.
I'm trying to think how many of these, like the classic disinhibitory modality studies, have actually tried combinations. Typically, you see either, the isolated use of one of those adjuncts, the absence of it, or combined with therapeutic exercise. And I think there's certainly benefits. Any of the evidence suggests there's added benefits in pairing the adjunct with therapeutic exercise and not simply using any form of, modality or any of these, interventions that we talk about in isolation. So that's, I think, number one. One of the first things that comes to mind is, I think, Lindsey, your dissertation work. So you paired NMES and eccentric exercise. I'm mixing up all of the data in that one. I thought there was some evidence of a little bit of added benefit, but not so much that warranted the use of the combination. And so really, I think, correct me if I'm wrong, really, I think there's probably a bit of work to do in that area to understand the contributions of multiple interventions paired with one another. I think the first thing from a mechanism standpoint early on is just, obviously addressing the effusion, pain, as well as those are really common sources of inhibition. And for that reason, I think focal joint cooling and sensory tens are nice adjuncts for the sake of, treating the inhibitory kind of mechanism, in addition to providing some, comfort to the patient potentially. So that's kind of where mine goes. But I think there's probably a lot out there that we don't understand about combinations. But for now, I would say we would probably lean on pairing any one of these with exercise itself.
Sure. Yeah, I mean, none of these have been studied, or none of these have been shown to be effective in the absence of exercise. These are adjuncts to exercise, and you can't get a muscle strong without exercising, right? So clinicians are busy. They have very limited time with patients. And so at what point do you think using these disinhibitory interventions may become a distraction? Like, we have to do the basics well, and in the end, these are just adjuncts, right? So is the juice worth the squeeze, and when isn't it?
Yeah, so I think that's a really good point. Obviously, a recurring theme is keep it simple and do the foundation of therapeutic exercise well, right? And so any one of us, we read any paper that comes out, and there's always new theories or new interventions being investigated, and it's really easy to get kind of that shiny object phenomenon and get distracted and lose track of the core components of rehabilitation. And so what I do think would be helpful is if clinicians dedicate some thought to the problem at hand, right? And assess, what means do they have available to them in their clinical setting? Do they just have ICE? Do they have NMES? What is it that they have available? And then what does the evidence say about what they have available? And I think for the most part, given what we know about kind of this breadth of interventions that have at least been tested and have some evidence of benefit, I think more often than not, there's some really basic, things that most clinicians have available to them. So I don't think it has to be go out and get a whole body vibration platform and do all these crazy things. I think when those are available, certainly explore those as opportunities. But keeping it simple in terms of the things they have around the clinic, I think is the way to go.
Great. So there's a series of kind of follow-up questions that I'll direct kind of to the whole panel. And this is about using modalities to augment exercise. One of the questions is, what's the preferred disinhibitory technique to treat muscle weakness, quadriceps weakness specifically? Is exercise alone effective, which I think Grant commented on? And then what happens when a patient, this is currently in the chat now, doesn't tolerate ice or high intensity TENS? What are the other options? What do you go to?
I mean, Troy Blackburn. Go ahead, Lynn.
I'm going to jump in and just say that, I'm a huge electrical stimulation proponent, as most of you know. One of the things you have to do is work with your patient with electrical stimulation. Lindsey and I talked about this morning. You have to tell them from the beginning, you will.
Oh no, she froze for me. I don't know.
Yeah.
Others. Yeah.
That she was going to say, you will not like this, and that's going to be uncomfortable.
Yeah, go ahead, Liz.
You take off summer and like setting
you finish, Liz.
setting expectations, right? Go ahead, Lindsey.
Yeah, I'll just jump in and say, like, there's a lot of things about exercise that are uncomfortable, right? Weightlifting is not comfortable, but people lift heavy weights because they know it makes them stronger, right? So I think like patient education on like, look, this isn't going to work unless it's strong. And if your goal is to be strong again, you got to lift a heavy weight or you got to take a high tolerance, right? And we can come up with different strategies to like mitigate the discomfort, which is something that Lynn and I talked about this morning.
Yeah.
But I think it's just like any other type of exercise, weightlifting, there's things about it that are just uncomfortable and you just got to get with the program. So I think there's that. I think like having a level of awareness that some people just aren't going to be able to push it the way you want it to push it. I think like on a preclinical level, that's why we're sort of looking at like other avenues for those people. But like, I don't know, eccentric exercise, like, or exercise with blood flow restriction therapy, do it at a lower intensity, same sort of benefits. There's a lot of other things that you can do with people that seem to target these issues. I think it's all about just like, what are you dealing with, right? Is this person have a lot of inhibition? Probably because it's early after surgery. Then find the modalities that have the best evidence to knock that down, right? If you're measuring with any form of measurement over time, you would know what this person is likely suffering from. So tailor the treatment to that, right? So it's just measure and then treat based on whatever the outcome is, right? Like I think it doesn't have to be like overcomplicated as long as you know what the prescription needs to be based on where the deficit is.
So I'm going to say, people have different coping strategies. So figure that out with your patients. Talk to them about how can I help you get to this therapeutic level of X, let's say current for NMES or weight for strengthening. And people are on this continuum of how they better deal with it. Do they want to be distracted? Or like most of us, do they want to know exactly what's happening? So they want to watch the screen, they want to see the numbers, right? But help them work with you, or you work with them to figure out how they tolerate, as I said in NMES, it's always going to be uncomfortable. So how do you tolerate this? What can I do to help you tolerate this uncomfortable level of current, again, for 10 seconds, right?
Yeah.
It's a big one,
Right.
There's so many different ways to work with people on this, but you have to do that with your patients, and you'll likely find a way to help that person through this struggle.
I would say just you level with them, right? Like explain it to them, take the time to explain it first couple of visits. And in my own patient work, I have found that, you know, people will, pretty much everybody will take it if you level with them and say like, look, here are the 5 reasons why you need to take this at a high intensity. Like you and I are going to do this together, right? Be side by side with them. And generally people get on board.
Just don't let them squeeze your hand. That can be very uncomfortable for the rehab.
I want to stay on NMES just for a few more minutes, maybe, because it's so important. It's probably the modality that all of us use, and the most effective in the evidence. However, I think, Lynn, you had mentioned this in your talk. Some of the evidence has shown waning effects, whether that's through like evolution of stimulators being less strong in the current day. What can we do, or what do you recommend as far as like wall unit versus portable unit? What are the best parameters to minimize discomfort? Can we do things like playing with pad size to increase contraction? Where do you stand on this?
Well, I think Lindsey and Liz especially can weigh in on this as well. But
yep.
Yes, it is true that the punch of the waveforms in simulator units has waned over time, right? But there are units out there that can deliver it. And I think what we need to do with rehab professionals is make sure that they understand that the most important thing is the punch of the waveform, the amplitude and the duration, basically the area under that curve. And all of the simulators that are for sale in the US have that, and actually internationally as well, have those data, right? Those parameters available to them. And what you do is you try it. I mean, you want to be at about, you know, roughly a 400 microsecond duration and as much amplitude as you can get. And if the stimulator that you have, you put it on your patient and they max it out the first day, that's not strong enough. So you got to do trial and error. There are some stimulators out there that can really do it. We've been testing some. There's a Dynatronics plug in the wall unit that is capable of doing this. There is the Chattanooga Continuum. There's a couple of others that we've actually tested head on, right? In our clinic. But the best thing for you to do is to take whatever stimulators you have. Most of the time, I think all of you know this, the therapists go in and they hit a button that says muscle contraction or whatever it is, or tense, or those stimulators have these ability for you to find and adjust that amplitude and pulse duration, you know, those things in there. So do it. Like try and figure out how to maximize the punch out of those stimulators. Or we have to find some others.
I think it's all just about being smart consumers. Like you wouldn't buy a washing machine without looking into it, right? The same idea and what the settings are that you need to run it. Like same idea here. Like you need to like crack the manuals. And us as rehab or as researchers should like maybe help with like understanding of waveforms a little bit better. But like be a smart consumer, like check and see what this unit can do. And if it gives enough juice or punch behind the stimulus, right? And then adjust it so you can get that with your patient. Otherwise, like you may be better off spending your time doing something else. But being a smart consumer, I think is kind of the key here.
Does that help, Dave?
Yeah, that's great. So two questions came in through the chat. One is, given the effectiveness of NMES, do you have advice regarding the frequency of use per week, number of sessions on average?
Or Liz, I mean, we do it every session, starting the first day. I mean, again, if we're talking about what we're talking about, quad dysfunction, ACL, or any intra-articular knee injury, so cartilage, meniscus, total knee, even. We do it every treatment, every session.
I would add in, Jen Stevens-Lapsley has done a lot of this work in the total knee population, and she has studies where they did it twice a day, post-op day one, every day for, I don't remember if it was a month or longer, and gigantic group differences between those that did standard strengthening. So I don't think we're in the same, this is not muscle strengthening and hypertrophy, it is input to the muscle. So we don't have to think about it as needing like rest days and things like that. And if you're in a setting where you can send units home with patients, let them borrow it or rent it or whatever. I think we could think about that approach to it, and maybe have even more success than just doing it twice a week when they're coming in to the clinic.
I'll just
So
add, like, sorry, Dave.
Go ahead. No, please.
I was just going to say, like, I don't think we have like the exact prescription down. What I think we know is more is better, and probably more frequent, and probably as early as possible, right? Like, based on the physiology of the injury. So I think within that context, do whatever you can to sort of meet those goals. And it's our jobs as scientists to kind of like rein that in for clinicians, and we're trying. But what we know now is high intensity as soon as possible, pretty much as much as possible.
Right, and a follow-up question is, what exercises are you actually using this during? More dynamic exercises, more isolatory quadriceps exercises, and when do you stop? At what point in the rehab process do you discontinue its use?
I'm going to jump in with that one pretty quickly. So we do it all the way through rehabilitation. I mean, knee extension is a huge component. And I think Liz and others can speak to this in terms of the development of PTOA. It's one of the most consistent things that can help prevent PTOI, which we're not even talking about in this particular situation. But we teach our patients who've had an intra-articular traumatic knee injury that they should be doing knee extension exercises for the rest of their lives, right? So this is something they need to maintain their quad strength forever.
Great. So I think this is a really great segue into my last question, which is, why do you think the myth about open chain knee extension and unsafe graft strain is still so widely held by physicians and physical therapists?
We're back to that history thing again, Dave. Back in the 80s and early 90s, when isokinetic devices were out there at the beginning, surgeons started to blame using these devices for loosening of their grafts. And you asked me what was the biggest thing that I've seen in my career, and I told you evolution of the surgeries. They had terrible graft placement back then. So you either got full extension and they were loose, or you didn't, and they, had patellofemoral pain. So it was one or the other back then. It had nothing to do with the isokinetic devices. And then, but even back then, the earliest studies show that the Vermont studies, which were studies using a strain gauge on the anteromedial bundle of the ACL, showed that knee extension with weight was, 3.9 versus 4 with closed chain mini squats with a sport cord, right? So they're very similar. They're virtually indistinguishable. And more recent studies out of Lou DeFreyd's lab at Duke have shown that with every step during gait, the strain on the ACL is somewhere between 12 and 14%. So that's 3+ times what you get with a knee extension with a 30-pound weight So where it is a huge mess. We've tried very hard. We're trying very hard. I think we're getting there because I think it is something that people have really understood is the wrong way to go, like to avoid closed chain exercise, isolating the quad for these quad strength things. I think we're very lucky for Matt and programs like this that are helping to get this out there. We also have in our group been able to contribute to the ACL rehab section of the Orthopedic Knowledge Update, which is the LKU is something that the orthopedic surgeons use to study for their tests or research. And we also developed the curriculum for the new residence curriculum for orthopedic surgeons that is mostly online and modular last year. So all of this is going to start to trickle down. We just need to get it out there, and we need to also perpetuate it in the community and to our own teachers and in AT and PT programs, that they're not perpetuating this dogma.
I was going to add that we need to be teaching it correctly to the future clinicians. And like when I talk to our PT students, I tell them somebody will tell you that it's the most awful thing to do and you will ruin their surgery. And that is scary. Like if you're a new grad and you think you're going to undo a surgery, you're going to avoid that. Like if that's a scary thing to think about. And so I forewarn them that you will find a PT or an athletic trainer or somebody that will tell you this myth and exactly what you're talking about here, Dave. Don't be fooled. Don't be scared. Come back to this evidence that we're showing you and share that evidence. But I think presenting it in that way is important and hopefully will help down the road. It takes a long time to undo that though.
Great. So in the interest of time, I thought I'd just wrap up. If you're attending this talk and you haven't already registered and taken the course, please do so. There's much content there that we did not get to. Grant talked about a number of other disinhibitory modalities to use as adjuncts for quadriceps strengthening. Liz had an excellent talk about the biomechanics of prescribing exercise in order to impact quadriceps strength and to improve the moment arm about the knee. Dusty had a great review of the kind of all the neurological considerations and the fallout of ACL injury. Lindsey spoke a bit about her muscle work and preclinical model using rats and ACL injury and how much it has told us in such a short time of the muscle physiology. And Lynn gave an excellent lesson of the summative review of kind of the ACL world and where it stands today in the context of its history. So amazing course, please check it out. And I'm sorry if we didn't get to your questions today. Thank you, panelists, for being here and answering these questions. And thank you, Matt, for hosting.